Assalamu alaikum. Now I would like to talk about renal tubular acidosis. In renal tubular acidosis, type 1, type 2, and type 4. Actually, type 1 is distal, type 2 is proximal, and type 4 is called hyperkalemic tubular acidosis. Hyperkalemic tubular acidosis. So type 1 is distal, type 2 is proximal, and type 4 is hyperkalemic tubular acidosis. What you have to remember that this is an odd number, so the odd thing will happen in here only, and the 2 and 4 would be kind of similar findings. In hyperkalemic tubular acidosis, their potassium would be higher, and in other two, in 1 and 2, the potassium would be lower. Okay, and if you find a patient that hypokalemia, and you are suspecting that he has metabolic acidosis, but potassium is low, then you have to see the urine pH. If urine pH is more than 5.5, then it is distal renal tubular acidosis. If the urine pH is less than 5.5, then it is proximal renal tubular acidosis. In hyperkalemia, there is urine pH is less than 5.5. So this is the way of differentiating. In type 1, I have already said that the odd thing will happen in here. In here, calcium is more, and the rest of the 2 and 4 calcium is normal. And type 1, D for DCT. In the type 1, defect occurs in the DCT, and type 2 and in type 2, P for P, that means proximal renal tubular acidosis, defect occurs in the PCT. On the other hand, in hyperkalemic tubular acidosis, the problem happens in seeding, that means collecting duct. What happens in here? In distal renal tubular acidosis, there is inability of the alpha intercalated cell to secrete hydrogen, so no new bicarbonate is generated, so there is metabolic acidosis. On the other hand, in proximal renal tubular acidosis, in here the defect happens in PCT, no bicarbonate reabsorption occurs, that's why there is increased excretion of bicarbonate in the urine, and that's why there is metabolic acidosis. On the other hand, in hyperkalemic renal tubular acidosis, there is in hyperkalemic tubular acidosis there is hypoaldosteronism. There is decreased aldo, and we know that aldosterone makes you retain sodium and excrete potassium. If there is low aldo, that means there is more potassium. So I have already find out that this person has more potassium. What are the association? Now I already said that odd thing will happen here, and 1 for 1, and you can say that stone, if you add st, then stone happens in here. In here there is propensity of developing calcium phosphate stone, calcium phosphate kidney stone. There is increased risk for calcium phosphate kidney stone. Why? Because there is decreased pH, that there is increased urine pH. As there is increased urine pH and increased bone turnover, and that's why there is a propensity of developing calcium phosphate stone. Okay, in type 2, for tickets, that means rickets, in type 2 there is increased risk of having rickets in Fanconi's anemia. And in type 4, there is no significant association. So in type 2 there is tickets, that means rickets, and in type 1 there is stone, there is increased risk of developing calcium phosphate kidney stone, as there is increased urine pH and increased bone turnover. Now the causes in type 1, the causes of type 1 can be remembered by this mnemonic 4A. 4A is uh, uh, amphotericin B toxicity, amphotericin B toxicity. A for anomalies, there is obstruction of the urinary tract, anomalies of the urinary tract or obstruction of the urinary tract. There is autoimmune disease, like SLE, rheumatoid arthritis, and Sjogren's, and there is analgesic nephropathy. So the type 1 renal tubular acidosis, the causes are remembered by this way, and the type 2 renal tubular acidosis, the causes are remembered by FMC, that means Fanconi's anemia. In Fanconi's anemia there is propensity of developing tickets, that means rickets, and in multiple myeloma and carbonic anhydrase inhibitor. Can you tell me the name of some carbonic anhydrase inhibitor? The name of the carbonic anhydrase inhibitor is acetazolamide, dorzolamide, brinzolamide, and last but not the least, type 4. In type 4 renal tubular acidosis, the causes can be subdivided into two types. There is decreased aldosterone production, and there is aldosterone resistance. In decreased aldosterone, there is diabetes, hyporenism, DM, hyporenism. There is ACE, there is ARB, there is NSAIDs, there is NSAIDs, and there is heparin, and cyclosporine, and adrenal insufficiency. These are the cause of decreased aldosterone production in hyperkalemic renal tubular acidosis. But there may be aldosterone resistance. What we will do in aldosterone resistance? In aldosterone resistance, the causes are potassium sparing diuretics. There is nephropathy due to obstruction. And one drug, TMP-SMX, helps here. And this is all about renal tubular acidosis. Now I would like to discuss about some acid base physiology. In acid base physiology, what will happen in here? First of all, you have to remember that M for same and R for reverse. By remembering this, M for same, that is MAC, and that means AC and AL. All you have to know that in acidosis the pH would be less, in alkalosis pH is high, and in acidosis pH is low, in alkalosis pH is high. And now you have to remember what should be reverse and what should be in the same direction. In MAC, in M for same, that means whatever the direction of the pH, it will follow the direction of the pH. If there is a decreased pH, decreased carbon dioxide and decreased bicarbonate. In acidosis, the compensatory metabolic acidosis, the compensatory mechanism is the respiratory system. The compensatory mechanism is respiratory system. So you have to to move out the acid, you have to hyperventilate, hyperventilate, hyperventilate. And in alkalosis, the direction would be same, the same direction, and you have to hypoventilate, hypoventilate, hypoventilate. In respiratory acidosis, the direction would be reverse, that PCO2 is high and bicarbonate is high. And in here you have to compensate by renal pathway. And for this you have to increase renal bicarbonate reabsorption, increase renal bicarbonate reabsorption. On the other hand, in respiratory alkalosis, the direction will be reverse, and you have to decrease renal bicarbonate. You have to increase renal bicarbonate to compensate this acid. You have to decrease renal bicarbonate to compensate this alkalosis condition. Now I would like to talk about anion gap. The the formula of the anion gap is sodium, sometimes potassium, sodium plus potassium, um, minus chloride plus bicarbonate. The normal value of the anion gap is 8 to 12, 8 to 12. If it is more, sometimes in metabolic acidosis we actually need these. Sometimes there is high anion gap metabolic acidosis, there is normal anion gap metabolic acidosis. Before jumping into the causes, there are other thing I want to discuss, that is that we call winter formula. In winter formula, PCO2 equal to 1.5 into PCO2 equal to 1.5 into bicarbonate plus 8 plus minus 2. 1.5 into bicarbonate plus 8 into plus minus 2. And this is the Winter's formula. If measured PCO2 is greater than the predicted PCO2, then concomitant respiratory acidosis. On the other hand, if measured PCO2 is decreased then predicted PCO2, then concomitant respiratory alkalosis. So concomitant respiratory acidosis when measured P2 is more, when measured is more, that is acidosis. When measured is less, that is alkalosis. When measured is more is acidosis, when measured is less in alkalosis. You have to remember this Winter's formula in winter season. This is Davenport diagram. In Davenport diagram, this is the place of respiratory alkalosis. Alkalosis, this is metabolic alkalosis, this is respiratory alkalosis. This is metabolic alkalosis. This is the portion of the acidosis. We know that the blood pH is 7.4, and the 7 more than 7.4 is alkalosis, less than 7.4 is acidosis. And acidosis and alkalosis, and and this is the way we are looking in the Davenport diagram. Now I would like to talk about the causes of acidosis and alkalosis. In acidosis, in metabolic acidosis, there is normal anion gap metabolic acidosis, there is a high anion gap metabolic acidosis. In high anion gap metabolic acidosis, the mnemonic is mud pile, that means methanol. There is uremia. There is DK, diabetic ketoacidosis. DK, diabetic ketoacidosis. P for propylene glycol, P for propylene glycol, I for isoniazide, INH, and iron tablet, isoniazide and iron tablet. L for lactic acidosis, L for lactic acidosis, L for lactic acidosis, uh, mm, lactic acidosis, E for ethylene glycol, E for ethylene glycol, E for ethylene glycol, and S for salicylates, E for ethylene glycol, and S for salicylate. And in normal anion metabolic acidosis, the mnemonic is hard as. The normal anion metabolic acidosis, the mnemonic is hard as. That means hyperalimentation. That means hyperalimentation. That means hyperalimentation. A for acetazolamide. A for acetazolamide. A for acetazolamide. R for renal tubular acidosis. D for acidosis, diarrhea. F for uh, Addison's disease. S for spironolactone, and S for saline infusion. Okay, this is the cause of metabolic acidosis, and then now the cause of metabolic alkalosis. In metabolic alkalosis, the causes are LAVH, love. That means loops, make you lose, loop diuretics. Then A for antacid use. A for antacid use. B for vomiting. B for vomiting. Or H for hyperaldosteronism. Hyperaldosteronism. Loop diuretics, vomiting, antacid, and hyperaldosteronism. And now the cause of respiratory acidosis. The respiratory acidosis, in respiratory acidosis, A for acute lung injury, A for acute lung injury, A for acute lung injury, C for chronic lung disease, C for chronic lung disease, A for airway obstruction, I for IPF, idiopathic pulmonary fibrosis, uh, D for depression, that means respiratory center depression, depression. O for obesity, hyperventilation syndrome. S for S for sleep apnea, and S for sclerosis, that means multiple sclerosis. And the last cause of respiratory alkalosis, the respiratory alkalosis, what have the causes of respiratory alkalosis, that is that is anxiety, panic, tumor, pulmonary embolism, anxiety, panic, tumor, pulmonary embolism, and hypoxemia, pyrexia, and pneumothorax. These are the cause of this metabolic. These are the cause of this respiratory alkalosis. Inshallah, you will be benefited.